right. So, hey, everyone. Welcome to our next ASES Virtual Journal Club on primary shoulder arthroplasty. We have an awesome panel tonight with Dr. Aboud, Dr. Sperling, and Dr. Zuckerman. We all know these panelists, but Dr. Aboud's at Rothman, Dr. Sperling is obviously at Mayo, and Dr. Zuckerman was my chair when I was at NYU, and we were thankful for their all participation in joining us. And we have Matt DiPaolo, who's up in Buffalo. He's going to be co-moderating tonight, and we've got some great articles. So please send your questions to the Q&A or the chat, and Matt's going to be manning them, and we're going to get them out to you. If you want to have an anonymous question, send it directly to Matt. If you want us to have knowledge who you are, and the question is, just put in the chat and we'll read it out loud. And thank you for your participation. So without further ado, we will get going. So the first article we're going to do is on the survival of pyrocarbon hemiarthroplasty in the young arthritic shoulder. This is a retrospective review out of France, looking at the survival and outcomes of patients less than 60 treated with a hemiarthroplasty. The hypothesis was that the pyrocarbon could be an alternative to hemimetal, which is associated with rapid glenoid erosion and a total shoulder, possibly avoiding the risk of rapid glenoid loosening in the active patient population. So they looked at 64 patients with a mean age of 53. The primary outcome was patients needing a revision. Secondary outcome measures included functional outcome scores, return to work, sports, and humeral head reconstruction, quality using the circle method, as well as glenoid erosion severity and progression using some guy named the Sperling classification. So the average follow-up was 33 months. Overall survival was 92%. The revisions were performed in 5 patients at a mean time of 24 months. PROs increased substantially in the cohort, and the majority returned to work and sport. The severity of preoperative and postoperative glenoid wear had no influence on outcomes. Patients who required glenoid reaming did not have progression of glenoid wear or difference in PROs, and non-anatomic reconstruction of the proximal humerus was associated with significant lower functional subjective results, more complications, and higher risk of revisions. So notably, the authors conclude that the additional of 1.5 centimeters of the metal disc under the pyrocarbon was associated with oversizing the prosthesis. So the authors concluded that pyrocarbon is a reliable procedure to treat OA in patients under the age of 60. So Dr. Aboud, maybe we could start with you. Given the results, when pyrocarbon is finally approved in the US for use, are you going to be an early adopter of this technology?
So newsflash, Chris, it was approved.
No, good, perfect. Now that it's approved,
even better question, more relevant now.
So I was involved in the IDE that was performed in the United States. I did 7 patients in that IDE. They were, in honesty, they were the hard patients that I had. And so they're typically younger patients, a lot of them with post-capsular arthritis, et cetera. And in general, I was encouraged. I have one now that's 7 years out. I think, and we use the exact same construct that Pascal writes about here. And I do think that the metal platform for impaction that you need for the pyrocarbon does cause a little bit of overstuffing. But in my mind, it was counterbalanced by the fact that you're not putting a polyglenoid. So I guess you're not necessarily adding that thickness of 6 millimeters or so of poly. I have seen some erosion in my patients. I'm not sure what to make of it clinically. It hasn't been progressive. It seems to have stopped after a year or two. But again, I only have a small cohort. I'm encouraged by it. And pyrocarbon has been around for a very long time. Its modulus elasticity it's much softer. And there's this theory that on the contralateral side of the joint, the glenoid side, where you don't resurface it, it creates a lubricated type of surface, kind of like the surfactant in your lungs, to kind of create like a film on the glenoid, so almost to like create neocartilage almost. Not sure if that's necessarily been shown in the shoulder, but there have been some basic side studies and hip studies that show that. So those are my initial thoughts.
So I just want to point out that, Joe, when you said surfactant in the lungs, you sound like an internist. All right. I just want to point that out. All right. Okay. Just so we recognize it. Right.
Thank you.
You were thinking that too, Sperling, weren't you? right?
Absolutely, Joseph.
Dr. Boone has a stethoscope in the background. I see it.
Listen, Joe, the study you were involved in, the IDE, were those results published? That's not
paper's not
study, right?
paper is not out yet. I know the paper's been in draft manuscript, but no, it's not out.
What were the overall results?
I have not seen the overall results.
No.
I have not seen the overall tabulated results.
So somehow I remember some early report on pyrocarbon that was not very successful, and this one stands in contradistinction to that. But I may be misremembering. I don't know.
No, I think
Anybody
you're right.
else?
I think the resurfacing in
right.
Australia has been a problem with fracture. Yes.
Okay.
So what do you think is the most, first, let's talk about the glenoid. So this study found that even with a retroverted glenoid, they were able to ream down the glenoid and didn't have any difference in outcomes. So is there a degree of retroversion that you'd be scared to just use a pyrocarbon and not use some sort of augment? And then what did you make about the progression of glenoid wear did not affect outcomes? Maybe we could start with Dr. Sperling on those, since you're the father of this classification.
I don't know. I think it's an interesting paper trying to address a difficult problem, but I think it's concerning. We saw even at the Mayo Clinic when one of my partners was doing an arthroscopic procedure for younger people with shoulder arthritis, there was progression. But then when you went back and had to do an arthroplasty on them, quite a bit of bone was missing. So you are burning bridges per se. The second aspect of it, and Dr. Zuckerman actually wrote one of the original papers on hemiarthroplasty for osteoarthritis. I remember that, Joe, that paper you wrote. And you did that when you were at Mayo, I remember, with Bob Cofield. So I remember that very well. And I'd love to get your thoughts on this. We continue to look at the results at Mayo. We never found a difference actually, or an improvement by reaming the glenoid. We actually found that you made the patient worse. So if you do a hemiarthroplasty, it actually makes it worse reaming the glenoid than if you left it in a biconcave. That's at least the results at the Mayo Clinic. And it's a challenging group of patients. But Joe, I remember that paper on pyrocarbon as well. And those results were not good. One of the ones that is different than when we heard today. But I think you wrote the original paper, or one of the originals, on hemi for osteo. I'd love to get your thoughts, Joe, at an historical perspective.
Yeah. So historical perspective, I wrote an article on that too for the Journal of Bone and Joint Surgery. That was from time I spent with Bob Cofield. Those are his cases. We looked at osteoarthritis and rheumatoids and the results of hemiarthroplasty. Now, keep in mind, that was done at a time when people were still reluctant to use the glenoid in certain situations, and it's different than it was today, because that was in the 80s, and they represented cases that were done then and before then. Where I've come to through the years is I am not a hemi enthusiast. All right, that's just the bottom line. I will do something on the glenoid side whenever I possibly can, because I think the results are better, and I think that the glenoids are better now. So when I see an article like this that says, hemiarthroplasty in the young arthritic shoulder and the age is less than 60, I wouldn't hesitate to do a glenoid in many of these patients, right? Albeit the reconstruction may be difficult, but I think the results are that much better. And I share your concern that it's with any degree of progressive glenoid erosion, glenoid reconstruction becomes that much more difficult, right? So, and the results in this paper were somewhat inconsistent about glenoid wear. It was really hard to say consistently what factors would produce glenoid wear. I was very surprised that even when they ream the glenoid, and you would expect that would expose some, cancellous or subchondral bone, that didn't seem to be a factor in progression of the erosion. They're very surprising to me. So I have this, when I think early adopter, all right, Joe Abood comes to mind. He is an early adopter. He has led the charge on not only things like this, but a lot of other things. I'm not an early adopter. I'm going to let Joe figure it out, right? And then I'll use it later on when the data is better. And I'm not there on pyrocarbon yet on this.
Dr. Zuckerman, I have a question for you. So your former resident, Dr. Clifko, comes in. He's clearly got some arthritis in his shoulder, early arthritis. He likes to lift weights. He likes to row. He likes to box. What option are you going to offer him at this point? He's failed injections. He's failed therapy. What are you going to do for this guy who's What are you, late 30s?
He's 38.
38 years old. All right.
I put up big weight. So
he puts up big weight, and he's not going to stop bench pressing. So what are you going to offer this guy?
Yeah. Well, listen, you're going to go through all the conservative measures, but somebody with end-stage osteoarthritis, and I'm talking about end-stage, in which all the conservative methods have failed with osteoarthritis. At 38, I would do an arthroplasty. Right. I would resurface both sides with a glenoid. Yes.
What about the rest of the panel?
With a hybrid glenoid.
What about the rest of the panel?
I'd enroll him in the stemless IDE reverse.
Reverse.
Just kidding. Just kidding.
Okay.
You can share your weights.
We're recording this, by the way.
You know,
that's because Abood is thinking of his physiologic age, not his chronologic age.
No, you guys would never be invited back to this.
It is a difficult decision, and I think that if someone decides on a Hemi, I quote them about 65% pain relief. Versus an anatomic with a glenoid, probably closer to 90-95% relief. And the glenoid, the way the glenoids are manufactured these days are lasting much longer. So, I think a 38-year-old will probably get a good 20 years out of it. And with a stemless, should be reasonably convertible to a reverse in the future if that's necessary.
And I would do a stemless anatomic with a hybrid glenoid, and I would definitely use some form of instrumentation on the stemless. I would not freehand the cut. I think that if you're going to do an arthroplasty, particularly stemless, I think we've seen now that freehanding the cut can in many circumstances can be challenging, and stemless can be more challenging than a stemmed implant. So I always use an extramedullary guide when I use a stemless implant. Just one little tip that can be helpful.
And do you tell them not to bench press anymore?
I mean, for me personally, I tell my patients roughly a 25-pound weight limit with the total. And I tell them they have 95% chance with an anatomic, 25-pound weight limit, hemiarthroplasty, 75 to 80%. They can go back and lift whatever they want, and it's their choice. And most people, it's not a dilemma. They either come in and say, I can't sleep at night, I'm miserable, I want pain relief. They choose a total, or they say, I want to chop wood, I want to be active with no restrictions, I want to do a partial. And the next question always is, if you do the partial and it doesn't work, can you do the total? And the answer is yes, but it's not as good as if I did the total to start with. So that's typically the progression. And if you have this discussion with them and you let them go home and think about it for a few months, when they come back, I think they self-select, and it's almost never a dilemma for patients.
And that's the difference between a Mayo Clinic and being in New York. Is when they come back in a few months in New York, they've seen 6 other orthopedic surgeons, right? Twice, right? And they've got 5 other opinions, all right? So
that's right. That's right. That's right.
Listen, about the weight thing, I don't think anybody knows the answer to that, but I just, for information's sake, I tell my patients they can lift weights at the shoulder level and below. I try to have them avoid over the shoulder level, and they can do any weight that they can comfortably do at least 10 to 12 repetitions. Right. And most people are going to, that's going to limit in the range that John has said. Right. Nobody's going to go nuts with this.
You're right, Joe. No one knows the number, right? So my hip and knee partners let patients play doubles tennis, not singles tennis, right? Where does that come from, right? Yeah. So a lot of this is out of thin air.
The pickleball's fine, though. Pickleball's good. That's easier. Right? Wait, question. While we're on the young patient, how many of the panelists discuss the fact that a young male has an increased risk for a C. acnes infection? Do you talk about that at all, and what your preventive measures are?
So I'll just jump in there. I treat the risk of infection basically the same in every patient I operate on who has a primary arthroplasty, who has never had any shoulder surgery before. Once they've had any shoulder surgery, including an arthroscopy, I cite the potential for an increased risk otherwise. And C. acnes is part of the discussion. I don't differentiate based upon age, though.
Yeah, I agree with Joe. I don't. And the longer I do this, I think that the number one risk factor for infection is the length of the procedure. So with a dedicated team, an efficient operation in a short period of time is the key. The more that there's dust from the computer floating in the air, the nurse anesthetist walking in and out of the room, and making sure you have a dedicated team. I asked our Ortho ID colleagues who are very well connected around the country. They estimate that since COVID, the risk of infection for a joint has gone up 30 to 40%. And they think that one of the biggest factors is a lack of dedicated teams that people have in the OR now.
Interesting.
Oh, that's amazing.
Right. So that brings us to 15 minutes. So we'll go on to the next one. Dr. McDonald also said that he thinks I should get a total shoulder, even though I think it's probably more like resection arthroplasty at this stage of my life. Okay. So let's go to the next one. The Neer Award in 2016 on outpatient total shoulder arthroplasties in the ambulatory surgery setting. And the title is it safe for inpatient total shoulders at hospitalists in a matched cohort study? So this study states that there's a recent emphasis on safe and efficient delivery of high quality healthcare, which has increased interest in outpatient total joints. The purpose of the study was to evaluate the safety of outpatient shoulder arthroplasty by comparing episode of care complications in matched cohorts of patients with anatomic TSA as an outpatient or inpatient procedures. 30 patients with outpatient TSA at a freestanding ASA were compared to age and matched cohorts of a traditional inpatient TSA and 90-day episode of care complications. There were no significant differences between ASCs and hospital cohorts regarding average age, ASA scores, body mass index, and no patient required reoperation. There were no hospital readmissions from either cohort. Minor complications in the ASC cohort were arthrofibrosis in 2 patients and minor asymptomatic anterior subluxation in 1 patient. The only major complication was an outpatient who fell 11 weeks after surgery and disrupted the subscap. The minor complications in the hospital cohort were mild anterior subluxation, blood transfusions, and DVTs. The complication rate was 13 versus 10%, and there were no significant differences. So the authors concluded that outpatient TSA is a safe alternative to hospital admission in the appropriate setting. So Dr. Zuckerman, you've been a chair for about 50 years now. Did you ever get to the point where you think that we do outpatient total shoulders?
Having trained in Seattle with Rick Mattson, we used to keep the patients in the hospital for about 10 days. All right. From the point where they had to get a certain amount of passive forward elevation, a certain amount of external rotation. So we've come a long way since then. There's no doubt about it. But when you think about it, what's driven the whole change in length of stay and inpatient versus outpatient, right? It's been driven by, healthcare reimbursement, right? Either the hospital is trying to save money on the expense side, or the payers trying to save money on the paying side. And so I think that patients should be in and out of the hospital as fast as they can, because the longer you're in the hospital, John Sperling talks about the duration of the operation causing problems. The longer you're in the hospital, things go awry. There's no doubt about it. Hospital-acquired infections, things as such. So, but from my point of view, right, I think doing a total shoulder replacement, either an anatomic or reverse in an ambulatory surgery center, which they go home the same day, is great for the patients, right? But I don't think it may be great for the patient, but I don't think it adds all that much to the armamentarium of what we do, other than being able to say the patients went home. Now I don't operate an ambulatory surgery center, but I have patients that go home the same day after a shoulder replacement. Usually they're younger. We send them home with an indwelling catheter for their interscalene block, and they tolerate it reasonably well. But for the most part, I think having a patient stay overnight, going home the next day, I'm comfortable with that. Now, let me just say a few words about the financing aspect of this. So if particularly when it comes to the cost of implants and particularly reverses, if you send somebody home in an ambulatory surgery center or the same day, the reimbursement to the facility, whether it's the institution you work or the ambulatory surgery center you own, goes down significantly. It's hard enough to generate margins with the high cost of implants, particularly reverses. And now we've just basically, cut the reimbursement by, I'd say, a third to a half, right? So I think that there's a lot of reasons to think carefully about how much we offer a ambulatory procedure. Now, keep in mind, as you pointed out, right? I've been running a department for a long time, and I focus on these aspects of reimbursement and healthcare financing. But Joe, I mean, if you were you guys have ambulatory surgery centers. You have to think about this with the reimbursement side, particularly with the cost of implants. So I don't think that it's as great an opportunity as some people do.
Yeah, I piggyback on that. Our hip and knee colleagues were early adopters, and one thing they've seen is, first of all, a hard time getting patients to be pre-certed for a overnight or so if they have social issues, no support, they're dependent on a cane or a walker, etc. And the other thing is they've seen reimbursement decline, right? So if a procedure is done as an outpatient same day, it's thought by the payer or the powers that be that it's not as difficult a procedure. The RVUs or the reimbursement of it should go down. So we have to be careful that it's not a race to the bottom. The more efficiency you show, the more they expect. And at some point, you really have removed all the fat. Now you just have the meat. And what are you going to do?
The most expensive part of any hospitalization for surgery is the first 12 hours, right? They're in the hospital. That's when all the resources get utilized.
I would just like to shout out for Quinn this study was done in 2012, 2015. I mean, the foresight that they had to do this study a decade ago is amazing, right? I mean, they didn't know about COVID, and that was a basis for a lot of adoption by us for outpatient surgery since COVID as well. So tremendous. And these were all anatomics, which I think a lot of those tend to be in some ways harder operations than reverses, even though our reverse population tends to be a little bit older.
I think that's right. I give Quinn a lot of credit, and he really was the pioneer behind this. I think one thing I've learned from Quinn, he did a wonderful webinar for the practice management group on outpatient shoulder arthroplasty, is the alignment of incentives. And I think at the end of the day, I think what we've learned at Mayo is it has to improve patient satisfaction. It has to be safe. And it's not for every patient. I think clearly all of us have recognized for some patients where this is probably not ideal. But I think the machine is up and running. A lot of institutions really learn how to do this in a very safe and effective way. And if you're considering doing this, thankfully, we have a lot of colleagues in ASCS can show you the right way to do it.
That's a good dovetail. Are there specific criteria that you would want to highlight that would lead you to either do one in an ASC or not do one for patients?
You know, it's interesting. I was at one of the Orthopedics Today roundtables, and what I was with a number of the hip and knee surgeons, and there was institutions where I thought they were going to say that 90 to 95% of their hips and knees they can do as an outpatient. But I was somewhat shocked when they said the number was 60 to 70%. And I look at my own partners now at Mayo, it's probably 70%, but it's not a 95% number. So I think, using good judgment on that, and I think all you have to do is have once in your career, need a vascular surgeon to come into your operating room and help you out, or need someone like that. And it'll make you think very carefully what would happen if I was out at an ASC. And I think we've all heard of colleagues that have been stuck out at an ASC and needed help in that way, and it can be challenging. So just be aware those things can happen.
Yeah, and
go ahead, Joe.
That's an important point, because you can send people home the same day from an institution, all right, or from an ambulatory surgery center. That's why I get my comfort level from being in an institution where something like that goes awry, right? But it's the same, healthcare financing situation in an ASC versus an institution. So the question here is, is it outpatient total shoulder arthroplasty, or is it outpatient total shoulder arthroplasty in an ASC? Those are two different considerations.
There's a question from the audience. For early surgeons in their career who are in the board collection, is there any advice on considering TSA use in an outpatient setting? Would you advise keeping most patients for at least one night in the hospital? Do you think early surgeons should be concerned about this in board collection?
I think if you go toward, if your system is set up with nurse navigation to make sure that it's done safely, I think at this point, it's very well accepted to do same day arthroplasty and discharge the patient. So I don't think it's a board issue. But of course, you got to look at things like BMI, comorbidities, et cetera, and social support.
Joe makes a great point, because you can't, you need to have the infrastructure in place to make this work, right? And if you don't have the infrastructure, then things are more likely to go awry.
Dr. Sperling, do you think that it's safe to do outpatient arthroplasty in the Medicare population? Do you have any qualms about that, or at this point in your career, is it safe?
Yeah, I think that's right. I think it's again, carefully choosing the patients. I think another part that's not talked about as much is the postoperative pain control, because it's amazing. I had a discussion with our anesthesiologist today, the incredible variability that exists even within health systems about that. So it's routine. Mayo Clinic in Rochester, the hospital I work at, patients get a one-shot interscaling block or get an indwelling catheter. So I think that's good. But there are other hospitals in our health system where the patients don't get a block. And I find that, I couldn't believe that at first when I heard that. So there's variability. So if you're early on in your practice and you're going to start doing outpatient arthroplasty, I think rule number one, as I said, is the patient has to be satisfied and comfortable, and it has to be safe. So you have to have, as Joe said, you have to have the structure up and running. How am I going to make sure that the patient doesn't have incapacitating pain at 1 or 2 in the morning? Because if you're early on in your practice, it's going to be a massive patient dissatisfier and not a great way to build your practice.
There's another comment from the chat. Dr. Alcusi mentions that if TSA becomes approved as an outpatient procedure, the RVUs will go down and decrease by a minimum of 4 and up to 6. And this is a comment I've heard also made by Dr. Romeo, that be careful what you wish for. And this gets to, I think, what Dr. Aboud also mentioned, that there's a tendency to sort of ratchet these things down. I know in town here, what the arthroplasty surgeons have done is negotiate specific deals for the outpatient surgery. So you have to show it that it's actually valuable. And if you are going just by Medicare, that could be an issue. So everybody seems to be on that same page. Chris, we're getting close to 15 minutes here. Any other final thoughts before we move on to the next article?
Okay, awesome. So why don't we move on? Thank you, Matt. Why don't we move on to the stemless RSA systematic review? And we don't typically do systematic reviews, but this is a timely topic on a new implant that we thought would be fun to discuss. So like I said, this was a stemless RSA systematic review, which is a very relevant topic in the evolution to a stemless anatomic and now the beginning of trials with regards to reverse. So 2 implants were identified from different companies. There were 437 stemless RSAs. Average age was 73.8 years. Follow-up range from 6.4 months to about 100 months. There was humeral loosening rates of 0.2%, complications of 11.2%, which included intraoperative humeral fracture, dislocation post-op, glenoid dissociation, and periprosthetic humerus fractures. So in conclusion, this was an interesting study showing the promise of a stemless component and could potentially be the first step in a larger prospective evaluation of stemless RSAs in different components. So Dr. Sperling, what are your overall thoughts on stemless RSAs? Are you going to be an early adopter to this, or are you going to prefer the long stem moving forward?
Yeah, it's interesting. When stemless anatomic came out, I spoke to my friends in Europe. They were saying, well, I do a stemless anatomic 95% of the time. And I said, wow, I don't know if that's possible. But in the past, probably 2 to 3 years on the anatomic side, for me, it's about 95% as well. So I think it's shown real promise on the anatomic. The question is, with the stresses that we're going to put on a reverse implant, is that going to survive? And particularly what makes me want to see the more data is the initial postoperative period. So you get boning growth, right? So in the postoperative area, when the patient abducts their arm, they have a light block, what happens early on? So I think there's promise, but I think we need to see data in terms of what's the biomechanical fixation at time 0, and also some long-term data. I'd love to hear Joe's thoughts. I know Joe's been involved in, again, some of the IDE work on stemless reverse, and I know Joe investigates things thoroughly. So Joe, love to hear your thoughts on the background research you did on this area and your experience with an IDE.
Yeah, so there's several IDEs going on in the United States. I'm involved with the Lima IDE, and talk about changing the glenosphere is poly and the liner is metal. So totally, it's a reverse of a reverse, right? So totally different way of thinking about things. but that's because they wanted their shell to be inlay, not onlay. And that's a big issue because, if it's inlay, the probability of getting better support from mechanical forces is going to be higher than onlay. So if you look at the, and we can, I guess, talk about brands here because I'm not conflicted, FX versus the tests, right? Very different. And so you wonder the support on those and what's the loosening of the humeral component going to be like. So that's always concerning. So Lima has quite a bit of experience. They've recently started publishing some of their data. I've used them now for about a year, and I've been a very slow adopter. And the cases have been fairly straightforward, cuff tear arthropathy cases. But so far, and I only have about 18 months experience with this now, so far, in following up for the IDE, I haven't seen any humeral-sided problems. But I have been very selective, and I've only done it now 3 times. So, I think we move cautiously towards this, and I think we will move that way. It's just the designs have to be considered of the humeral side.
So of those 3 cases, Joe, did you intend to do it in 3 cases, or did you intend to use a stemless in more cases and found the bone unsatisfactory? Because that's been one of my biggest issues with using stemless more often, right? Is the bone quality.
Yeah, so I haven't had to bail on them because the bone quality was poor. Now, I will say that these were patients that were probably on the younger side, say late 60s, versus some of my patients who are in their early 80s that I would consider a reverse in. So no, I hadn't had to do that, but I think that's truly a possibility. And yes, we do have the stem components available in the room, just like for an anatomic these days.
Joe, that's exactly what I was thinking. Because Joe, probably since you started this IDE, you've probably done what, 300, 250, 300 reverses. I thought you were going to tell me that the number you've enrolled in the IDE was much higher. So that brings up another question. Are we cherry picking the people who are going to get a stemless reverse as a part of an IDE? And then is it applicable to a broader population of older folks? Love to hear your thoughts, Joe.
Yeah, so I think we are somewhat cherry picking, but it's not based on the bone. It's based on the entire patient, right? So, to enroll a patient in an IDE that's randomized takes a certain level of conversation, understanding, consenting. That's pretty sophisticated. So I think that selects out certain patients. And that's oftentimes the reason it takes so long because, they start to ask you, they ask you a lot of questions and they decide they don't want to sort of be randomized the week before surgery. They want to know what they're getting going into surgery. So that's where I think, the randomization kind of is an issue. But yes, I do think there's clearly bias in these, right? For sure. And if you look at probably the previous stemless IDEs that were done for the anatomics, there was bias in the patient selection.
Great insights. Thanks, Joe. Appreciate that.
I have a question for the panel. So Dr. Zuckerman, you were a protege of Dr. Mattson, and Dr. Mattson talks about an impaction grafting technique he uses. He continues to use a standard stem with an impaction grafting technique and a relatively low canal fill stem. So the question is this a solution in search of a problem? In other words, is the humeral side truly a problem that we should be devoting all of this time and money to? When Dr. Mattson tells us that we could just impaction graft a standard stem and not worry about it. What does everybody think?
Well, whether you use Dr. Mattson's technique of impaction grafting, but let's look at the data. The standard length humeral stems have been around since the 70s, right? And the only problems I've had with standard length humeral stems is sometimes you get stress shielding and you get loosened bone proximally. The difficulty of revising them, particularly if they're cemented in place, but for the most part, they perform very well. And the justification for shorter stems or even progressing to stemless was in part so you could preserve bone, which is a worthwhile goal. But the question is it adequate justification for a whole new series of implants? Now look at the problems we have with short stems. Some of the short stems, in which the metaphyseal fill is greater, cause even more bone resorption proximally. So if you ask me, do we have a solution to a problem that didn't exist? Maybe a little bit, but I'm all for innovation and looking at new ways to do things, and I think that's what you're seeing here. New ways to do things to accomplish the same thing, and I think it's worth it in that regard.
I think going back to John's comments earlier, I mean the cut of the neck shaft angle here is critical, right? Because you don't have a stem anymore. So whether you use some sort of extramedullary guide or what have you, you could really change your neck shaft angle significantly depending on, your philosophy and the thought behind how you pick your neck shaft angle. So again, challenging for a stemless RSA to make sure that's accurate.
Dr. Boo, do you have any other technical pearls from your experience? Like, what have you done to make your RSA stemlesses successful?
I can't tell you that I have like any specific pearls other than what I usually do with every RSA, which is, typical approach, exposure, getting your osteophytes off, making sure you release circumferentially around the capsule and labrum. Tend to put it, because the one I use here is a different from the neck shaft angle. I typically tend to put the base plate a little bit lower than I typically do with the other system that I use. But otherwise, that same feel that you want to get, the nice little pop when you put the liner in. Good rim support. You got to have good rim support. You make sure that the shell is well seated in the proximal humerus. This is an inlay system, and you want to make sure you got nearly 100% peripheral rim support on it.
Yeah, that's awesome. That's great feedback. So, Dr. Sperling, do you think you're going to be an early adopter? Have you done any yet?
No, I haven't done any yet. And I think, I saw in Europe some of the successes, and I also saw some of the failures. And I saw some of the immediate failures, again, where some unfortunately were displaced in the recovery area, where the surgeon thought actually it was well fixed and the patient raised their arm and bottle capped the implant out. So I've seen some of those. So I think for me, it's what is the time zero fixation, I think is critical until we get bone ingrowth in there. And then some of the longer term data. And I think we'll learn from others like Joe that are having experience in this regard. So I'm like Joe Zuckerman. I'm optimistic about this. I think innovation's great. I've noticed on stemless anatomic, why do I do that? I think it's faster than using a stem component. I think it's less blood loss. And I think if you don't violate the canal, in general, a lot of surgeons believe that patients have less pain. So I think there are upsides of stemless in that way.
I think the stemless also is an easier operation the bigger the person gets, right? Because I think that, when you got big muscular people, you tend to be young people, the weightlifters that come in, all right? I'd much rather do a stemless because access to the humeral canal is not required. So that's one of my indications for a stemless.
Dr. Boot, have you found that that's been a quicker procedure, or is it relatively similar to your stem procedures time-wise?
Similar, but again, given my frequency of utilizing the system, I think I'm just slower and more deliberate and careful that I'm doing it right, which is, same thing I do with my typical one, but I use it so frequently that it's not as much, tread with caution.
I mean, when you look at the results of this systematic review, the complication rate is relatively small. I mean, when we're talking about 2% dislocation, right? I assume the periprosthetic humerus fracture may have been was post-op, when that can happen to anybody. It's more of not a product of the operation itself. So these results, at least as reported in the review, are very impressive.
Are there any biomechanical considerations you have to take? Like, do you have to consider maybe using a zero poly or a smaller poly to try and recreate the center rotation a little bit to not have that varus tip out that they're describing? Is there any consideration for that, or do you think that a standard poly, a 6 or whatever, is okay for these implants?
I can tell you that in some of the research I've looked at and we've talked about, you don't want to upsize it. If you're upsizing the poly, then you probably need to go to a stem, because I'm not sure how much you can tolerate with upsizing the poly. So you got to be careful about that. Your size options are limited. And if you're having to do that, you should probably be using some sort of stemmed implant.
So do you use a more lateralized glenosphere to have to decrease the size of the poly? Or is there any glenosphere considerations you do that are different for a stemless reverse?
My glenosphere considerations on the stemless are very different. They're Grammont style versus I typically use a Frankel style on my stemmed implants. So they are limited options as far as how much you can lateralize off of those.
Dr. Sperling, Dr. Zuckerman, any considerations that you think, or do you think that we're going to be able to have a poly that's more narrow to prevent the varus tip out, or are you concerned with having a wider poly, or what would you do for the glenoid side if you had to do it?
Listen, I think this is going to evolve. On one hand, this is a nice review. On the other hand, it's 437 cases, which is a small number, right? I think that with IDs like Joe's involved, and we're going to learn some of the nuances of this that will help us mostly in patient selection, right? To me, that's the key. There's two things that can undermine success: poor patient selection and poor technique. I'm going to assume we can control the technique, but we got to know who's best suited for this.
I think there's a paper out by Alex Latterman by another system that shows a 9% humeral loosening rate at 2 years. So, again, I think that paper was on an on-lay type system. And then the other thing to mention about this paper is 165 of these were Versos. And I would say the Verso is more, and Alfred Levy is a great friend. The Verso is more of a mini stem. It's not truly a stemless in my mind.
Okay, well, that was an awesome review of stemless. Matt, any parting thoughts or questions before we move on to the BioRSA metal augments?
No, I think it's great.
Okay, awesome. So we'll go to the last article, BioRSA versus metal augments in reverse total shoulders. So as we all know, lateralization of the glenoid component is known to reduce the incidence of scapular notching and possibly improve the postoperative range of motion. The purpose of the study was to compare BioRSA to metal augment glenoid base plates, assessing clinical outcomes and base plate migration using model-based radiostereometric analysis. So this was a prospective RCT comparing BioRSAs to metal augments, and they looked at clinical outcomes and radiostereometric analysis. So 41 shoulders were enrolled. They were all marked with 8 tantalum beads in the glenoid and coracoid. Participants were imaged using calibrated stereographic techniques, and clinical outcomes were followed for 2 years. They found that there were no differences in clinical outcomes, but they found increased external rotation in BioRSA, in the BioRSA group, and they found no differences in the glenoid component in translation at any point. So, Dr. Zuckerman, you've been involved in the evolution of reverses. What do you think of BioRSAs versus all metal components?
Well, I have to admit to a significant anti-BioRSA bias, all right? Because I think the BioRSA came about when it was realized that the Grammont style implant with the medialized center rotation and the humeral neck shaft angle caused scapular notching. That was an unintended consequence of it. So the best way to address that was by lateralizing the glenoid. You couldn't lateralize the glenoid in this system because they would have to redesign the whole glenoid. So they put a bone graft in between, all right? There's a lot of other ways to solve scapular notching, all right, as other systems have shown. So to me, this was a mid-course correction of a design flaw. So as great as the Grammont prosthesis has been, and it has been an unbelievable advance that has laid the foundation for everything else we've seen about reverses, right? That was a shortcoming of it. And the BioRSA is an attempt to compensate for that. Now, I never made sense to me to put bone in between the implant because you have to get it to heal, you have to get it to incorporate. And I've been frankly surprised that they haven't had more problems with true graft incorporation. So I'd much rather replace it with metal. And when you look at what's occurred around hips and knees in terms of reconstruction and use of bone grafts, that does, and I know the shoulder is not the hip and knee, but there are some parallels. We learned from the experience with hip and knee replacement, bone grafts don't work, right? We'll put it this way. augments, replacing it with metal, compensating for it is more reliable with a higher level of success in the short term and the long term. So I think that augments are far better than trying to fashion a bone graft and put it in there. Now, I will tell you, when I read this article, and it's very well done, and I congratulate the authors on having a prospective randomized study and including stereoisometric component to it. But this says to me, yep, I'm gonna, augments are the way to go, not bone grafts.
Dr. Sperling, what do you think?
Yeah, I couldn't agree with Joe more. I agree with him completely. I think that what we've seen now in some recent publications, the problems associated with graft, right? So Brad Edwards, BioRSA, a third of the patients, the graft was either completely or partially resorbed. He presented at the ASCS meeting. Mayo Clinic study, 25% of reverse revisions, bone graft resorbed. The problem is some of those failed out at 3 years, 4 years. This study was 2 years. I think you're going to miss some of that resorption. And even from Joe's institution showed problems with bone grafting primary reverses. So I agree with Joe. I think the hip and knee surgeons are already telling us, we told you so. We figured this out a long time ago. You guys are behind us. So I'm like Joe, I prefer metal compared to bone.
Dr. Aboud, how about you? Same thoughts?
Yeah, I mean, I'm not a big augmenter with bone or metal, but when I do, I typically prefer metal. Kind of like.
Dr. Aboud, can you talk about that? You said you're not a big augmenter. In what rare scenarios would you do that, or what are your strategies for avoiding augments with deformity?
Yeah. So if it's a really severe deformity, I've gone to vault reconstruction systems. I've found them to be pretty reliable in those situations. And I would say mild to moderate. I've sort of hinged on 50 to 75% bone support and been fine without adding an augment or consideration of using the alt center line as Mark Frankel described. So those types of things have been my bailouts. But sure, you do have those cases that you need something a little more patient specific. And I think, systems are going towards more patient specific augments.
Dr. Zuckerman, I had the pleasure of training with you, and when I was your resident, we weren't doing too many augments. What percent of augments are your practice right now?
So I'd say 60% of my reverses get augmented on the glenoid side, right? And I think the reasons for that have a lot to do with the preoperative planning system that I use and into intraoperative navigation. I think that the degree of glenoid deformity, even small amounts of glenoid deformity, 10, 12, 14, 15 degrees of retroversion, there's a tendency now to address that with an augment. The augments I have are either 8 or 10 degrees in a posterior superior direction. So I think that has significantly increased the number of augments that I do. In fact, when I looked at before and after navigation, 100 cases of each, my use of augments went from about 22% to 48% just with the use of navigation. Now, whether that's necessary or not, as Joe points out, you don't need 95% contact here, although that's what I typically try and get, at least 90%, because I think it's going to help me in the long run. But many others have shown that you can have more limited bony contact. It's just a preference of mine to get that. And maybe it may be
it's
because—
interesting, Joe, that was my experience as well, doing more preoperative planning. And I think the article by Pascal Boileau, April 2019 in JSCS on the RSA angle, 21 degrees of superior tilt from the inferior part of the glenoid, you have to get that back at least to neutral. So you have 3 options to do that. You could eccentrically ream away the central and inferior bone. You can use a graft or you can use an augment. And my experience was like Joe's. Once I started planning the cases out, I could see how much bone I can save using augmented base plate. So funny, Joe and I did identical things, didn't talk to each other about it, but came to the same conclusion. And I'd say now I use an augmented base plate essentially on 100% of my reverses to correct the RSA angle rather than reaming away the bone.
So Dr. Sperling, Jacob Triplett asks, I'm a fan of metal augmentation. I think it offers several advantages, including subchondral bone preservation and increased base plate support. However, most of the systems that offer augments use a boss, which may argue that the vault bone removal is worse than the subchondral bone reaming. My opinion is that they are relatively equivalent, and at least the boss provides bone on ingrowth potentials. Thoughts, particularly from you, Dr. Zuckerman, and Dr. Aboud, more so Dr. Aboud, who's not a big augment user.
Yeah, I mean, I would say Tom DeQuinn at the University of Buffalo has done work on this. And everyone has their own perspective. I think the boss is great. I think what Jake said, I think you get a lot of stability and bone ingrowth into that. So I do like a boss on the base plate. But again, I think it's the recognition of how do we preserve glenoid bone? It's very precious. There's not much of it. And again, I find similar to Joe that metal is the way to go to try to be able to do that. Love to get Joe's thoughts, both Joe's thoughts.
You know, there's no doubt that a boss enhances the stability, the initial stability of the construct, and it's worth it. And there's a big difference taking out a little extra bone from the central portion of the glenoid as opposed to reaming it to try and correct 15 degrees of retroversion, right? In which you're taking it from the periphery and a lot of the subchondral bone. So I worry less about that when it's centrally involved in the vault.
I don't use a boss currently. I use a monoblock screw-in system, which, I do think preserves a bit more bone. But yes, truth be told, I'm conflicted with that, and I designed for that system, and they don't have augments. But again, I have not been as much of an augment user, and I haven't found it to be a significant clinical issue with my patients. Maybe I'm just not looking carefully enough, but I just be fully transparent about that.
So is anyone using BioRSAs at this point? It doesn't seem like there's a wide use from anyone on this panel using BioRSAs.
Not me.
Dr. Aboud, no?
I was never a BioRSA user.
Interesting. Yeah. Very interesting.
And I was happy that John Sperling pointed out some of the Brad Edwards results, because oftentimes when people who are most enthusiastic about the BioRSA, I frequently heard them say, well, at 2 years the graft is completely incorporated. Right now, it may not have dissolved, right? That's for sure, but incorporation is a whole different thing. I mean, we all took histology in medical school, right? And there's something called creeping substitution in structural grafts. That's a long-term process that involves resorption and then redeposition of bone. I don't think that happens with these grafts. I'd rather just have them sit there rather than actually be incorporated, because that's what causes the problems.
It's almost a surfactant type comment.
Touche, Joe. I knew that creeping substitution would get you.
Got me there.
I love that. Right.
So for those of you that use augments, do you have a size augment that you're concerned that's too big, or is that not a concern? Dr. Zucker?
So listen, I only have access for anatomics for 8-degree augments, actually 8-degree and 16-degree posterior augments. And in the system that we designed, the 8-degree augment is hybrid fixation. The 16-degree up until now has been a purely cemented polyethylene glenoid. I still use it in severe deformity. My colleagues who helped design the system, are waiting for a hybrid fixation model. So that's 16 degrees. But I think as more systems develop, there are other glenoid augments, whether it be anatomic or reverses, that can achieve, I think 10, 15, 20, even 25 degree augmentation, right? Although I'm not familiar with all the different types, but I've not used any of those. It's been pretty limited. When I have a severe glenoid deformity in a reverse that I don't think I can correct with the augments I have, I will combine it with a structural bone graft. Yes, I will.
I think that we'll need to see some long-term data, and I think some folks have some 2 to 5 year data on some of these bigger metal components that are, specific for the patient, and they are quite sizable. Whether they get backside ingrowth onto the bone, we'll have to see, because if we may see catastrophic failure at 5 to 10 years. We just don't have that data. But at 1 to 2 years, they seem to be they seem to be doing well.
And I do similar. So system I use and help design, it's 10, 20, and 30 degrees for augment on a reverse. And I'd say about 1 or 2%. I do what Joe does. And he mentioned use a custom glenoid for that patient. So I think it's the planning, I think, again, is Dr. Zuckerman pointed out, really is the key. Getting the CT scan, going through it, really understanding where's the deformity, and then what are my different options to be able to go ahead and match that.
Dr. Sperling, have you found that since you've done preoperative planning as well, that you've used more augments than before when you weren't using it?
Yes, I mean, absolutely. I think, again, for me, it just opened my eyes. I think Tom DeQuinn did a beautiful study, 50 consecutive patients and cases. I helped him with it. And then when I planned them, it was an augment in every case to get rid of the RSA angle. So again, if you have 21 degrees of superior tilt, as Dr. Frankel taught us, rule number 1, you can't have superior tilt. Every patient, you're going to have to correct on average 21 degrees. How are you going to do that? And I think what I found was with the augment, I can go ahead, preserve bone, and then at least get them back to neutral, if not 5 degrees of inferior tilt.
That's a great point. Well, we're coming up to the end of our hour. Dr. Aboud, Dr. Sterling, Dr. Zuckerman, any closing thoughts on anything we talked about today, augments, reverses, stemless, anything before we close down the session?
I think, great articles, great choices. And you can see the excitement around shoulder and elbow surgery, so much innovation. We're always pushing the envelope, and that's why it's such a great field. So thanks for hosting this.
Yeah, thanks so much for your invitation. Always great to be able to do this and really enjoyed it, Chris. And Matt, you did a wonderful job, and always great to get together with Dr. Aboud and Dr. Zuckerman.
And the only thing I would add is that, although we're doing this journal club, so the 70 or so people that have been listening, are supposed to learn from us, but there's no doubt that reviewing these articles and then listening to Joe Aboud or John Sperling and the questions that you and Matt asked, right, enhances what we do. That's for sure. I came away with more information here than I had before, and it's not about surfactant, right?
Free big substitution. Thank
I
you.
think that's a perfect point at which to drop the mic and end the webinar there.
Well, special thanks to Matt for filling in for Eric. Eric said we could reveal this, but it looks like his wife is going to labor right now, so he wasn't able to be at this. So we'll all wish him luck and be thinking about him. And thank you, everyone, for an awesome virtual journal club. We'll see everyone in 3 months for rotator cuffs. And thank you for joining us.
Thanks for having us.
Good night. Thanks, guys.
Thanks a lot. Thank you.
Bye.
Bye.
Bye.